Welcome back to KETV Newswatch 7's Chronicle. Since COVID-19 appeared, we've seen new antibody treatments and antiviral pills approved to help those most seriously ill. But a recent study by the CDC found not everyone may be getting those treatments. The study looked at 41 healthcare systems. It found lower use of monoclonal antibody treatment among Black, Asian, and Hispanic patients sick with COVID-19 when compared to white and non-Hispanic patients. Researchers say disparities might be a result of systemic factors like inadequate insurance coverage or lack of a primary care provider. The CDC says equitable distribution of treatments by race and ethnicity, along with vaccines, is essential to reducing inequities in severe COVID illness and death. I spoke to Dr. Jasmine Marcelin, an infectious disease specialist at Nebraska Medicine, about the inequities here in the metro. Dr. Marcelin says she's not surprised by the CDC's data.
This is something that we have been talking about for the entirety of the pandemic, that these disparities in healthcare have existed even before COVID-19. And unless every single decision that is made regarding the pandemic and how we allocate resources, treat folks, provide vaccines, test, if we don't do all of these things through a lens of equity, we will continue to see these disparities.
When we talk about the disparities, what can that look like for an average person in Omaha, Nebraska?
It means that let's narrow down to the medications, for example. We have very limited supplies of the monoclonal antibodies and some of the other treatments to help prevent people from going to the hospital from COVID-19. And so what that means is the institutions and federal and state official bodies have to figure out how to allocate those to people based on risk. Okay, so if we look at the risk factors that we have found for more severe disease from COVID-19, hospitalization and death, a lot of these are related to people's medical conditions that they may have. If somebody has kidney failure, if somebody has a condition that's making them immunosuppressed, et cetera. And all of these are very important risk factors that must be accounted for. What a lot of the risk stratification models don't account for is the fact that many folks who are living in Black and Brown communities may not have access to the preventive health care that they may need. And so therefore, they may actually have an increased risk of having high blood pressure, diabetes, or kidney failure. What we also have seen is when we looked at the deaths from COVID-19, especially early on, but even now, what are the ages that people are dying at? Age is something that has been used a lot. If you are over a certain age, your risk is higher. But what we found is that people in the Black community, in Hispanic communities and Indigenous communities, their average age of death of their elders is much lower than those in the white community. So if we stick to purely age as, all right, this is our main risk factor, we want to make sure we get everyone who's over 85 years old to get the medications or to get first in line for vaccines. That means there is a whole group of individuals from the Black community, from Hispanic communities, from Indigenous communities who are not getting access when they are truly at higher risk. That is something that we need to change in our thinking.
So it's not just, one size fits all. You really have to take in, from what I'm understanding from you, is you really have to take in, would it be considered a holistic approach?
Definitely holistic. There are definitely things that individuals, in terms of their medical conditions, that will put them at risk. But there's also environmental and structural and sociopolitical influences that also affect their risk. And we have to be able to account for all of those things when we're talking about how we can best provide that care for our patients and our communities.
When we talk about these disparities surrounding COVID, unfortunately, we know that it's not just COVID that, people of color, Black people have disparities with when it comes to healthcare.
Yes. Yes. There's definitely inequities in a lot of the different types of medical conditions. We talked about high blood pressure as one example. There's disparities in cancers, in colon cancer, for example. There are other infectious diseases, conditions where we see huge gaps in the people who are affected by those diseases. We're talking about things like HIV, sexually transmitted diseases. We see differences in how people are treated for their heart disease seems to be influenced by the structural racism that is baked into decision-making algorithms. We've seen differences in how people get access to care for their kidneys and get listed for kidney transplants or get placed on dialysis because there is a race correction in the kidney measurement that gives a different number for African American kidney function versus non-African American kidney function. And that is something that's baked into that system. And so that affects, even if a medical professional is not walking into a room and saying, I'm going to deny this patient dialysis today because they're Black. Most doctors are not going to do that. But what will happen is the system is built so that when you see these two numbers and you walk into that room and you say, oh, this patient is Black, this is their kidney number. If they were white, their kidney number would be this. So they don't get dialysis today because the number says that that's what their number is because they're Black, right? And that is something that affects people, thousands of people across the country when you think about when they could have been started on dialysis, which is life-saving, and when they could have been listed for a transplant, which is life-saving.
A lot of the time, the conversation turns to, well, they're not coming in to get, treated, or they're not coming in to get their exams. And I feel like that kind of, correct me if I'm wrong, it's a little victim shaming in a very different form, I would say. So it was nice to be able to kind of create the conversation of like, well, we have to kind of invite them in, instead of just saying, well, they could just come and, figure it out themselves. So I really appreciate that. And I want to know, do you feel like that narrative needs to change from what I just described?
Yeah, I agree with you. There is definitely, it's really easy for people in healthcare to say, well, they just don't come, or they just don't want to be vaccinated. For me, like that was during this pandemic, in the context of this pandemic, the whole idea of the unvaccinated that painted Black Americans as this monolith of people who are just opposed to vaccines, when that is clearly not the case, right? That really frustrated me. And there was also a second narrative that just made an assumption that people were hesitant. That was the word that was being used, and it was always or often attached to the second word that was being used was Tuskegee, and making it as, okay, well, this happened, and so people are hesitant, and there's nothing that we can do about it. And I reject that wholeheartedly. I think that so first of all, Black folks are not a monolith, and there are people who have questions, genuine questions. They don't know the answers to and don't have people that they really can trust to give them a straight answer. And there's a lot of misinformation out there. There's a lot of disinformation out there. And quite frankly, there is just a lot of confusing communication from healthcare professionals, from healthcare organizations, that makes it difficult for a person who really is unsure of what is the right thing for them or their family to make the decision. And so if we in the healthcare realm are talking about it constantly, like, oh, these are the unvaccinated, they're hesitant, they don't want to get vaccines, that is not helping those people who truly have questions. And so my approach to it has always been, I want to talk to you about vaccines and I want to answer whatever questions that you have. If I don't have the answer, I'll find the answer, but I will tell you that I don't know the answer to that question. And let's just talk through it. I have no agenda. Of course, as an infectious disease doctor, I want you to be vaccinated. I want you to be safe. And that comes from a place of love and caring for my community. But I'm not going to stand here and wave the vaccine over you and shame you if you have questions or if you feel like now is not the time. But I do want to know why today is not the time for you, or why you have questions about it and what you've heard. And if I can have that dialogue with you, and then at the end of that, you come out of it and say, I never really thought about it this way, or I was always hearing about this, but now I understand. Even if you didn't get the shot that day, that is a win for me, because it means that we've had a meaningful conversation and now you've heard and understood something about vaccination that you hadn't heard or understood before, and that is helping you on that journey. And that's my approach to it. And I think we do need to change the narrative and change the way that we think about folks who are not making the decisions that we in our healthcare ivory towers think that they should be making. And instead of chastising them for it, instead of shaming them for it, we should be inviting them in, as you say, and asking questions and being curious and trying to find out what are the barriers and what are the things that are worrying them the most. And usually when you have those conversations, you can uncover a lot of things about a person than when you just make assumptions about what they want or don't want.
Still to come, we continue the conversation on bridging the vaccine gap and what other healthcare groups are doing to build trust in the Omaha community. First, a reminder that your comments are an important part of this show. Email your thoughts to news@ketv.com. We'll be right back.